evening. Okay. I see a lot of familiar faces. Well, some nurses here, so I know to them I don't really have to introduce myself. But for those of you who don't know me, I'm Dr. Cherrilyn Crawford, clinical psychologist. And today I will be talking about depression. I am so happy to be here. I am passionate about mental health, so whenever I get the opportunity to speak about anything that has to do with mental health, I usually grab it. So I want to thank Nurse Rollins for inviting me here today to talk on such an important topic, because around the world, depression is very prevalent, not only in insane kids, but as I say, around the world. When we talk about depression, and we tend to refer to it as depression, and some persons might refer to it as clinical depression, but according to the Diagnostic and Statistical Manual of Mental Illnesses, it's really referred to as major depressive disorder. But for short, I will just say depression, because that is what all of us know it as. Okay? So depression, when we talk about depression, if we were to define it or to put it simple, we would say that it is a mood disorder that is characterized by persistent sadness and loss of interest or loss of pleasure in doing things that you normally used to do, and it can affect your daily functioning. So to put it mildly, that's how we would look at it. A mood disorder characterized by sadness, loss of interest in doing things that we usually do and used to find pleasure in doing. And it can affect our daily functioning. And when we say daily functioning, we're talking about all those things that we normally do. So yes, we show up to work, we talk about that. Problems in daily functioning. The chores we used to do in our home, whether it's chores as a mother, activities as a wife, etc., we will notice that persons who suffer with depression would have problems in these areas. Let us look at what causes depression. Well, the causes of any mental illness, they are biological, they are psychological, and they are social. And we're going to look at them from all these broad headings. So when we say biological causes of depression, we are talking about genes, hereditary. And what does that mean? Okay, if one of my parents had it, or maybe one of my grandparents had it, is a good possibility that I may develop depression or mental illness. Also, in terms of biological causes, let's talk about physical trauma. If you get in an accident, you hit your head, you damage your head. If the physical structure of the brain is damaged, then the functioning of the brain could be affected also. So that is what we mean when we say biological causes. People might go even further and say, but what about the role chemistry plays in it? Yeah. People would talk about chemical imbalances, such as, serotonin and dopamine, all those kind of stuff that, if they increase or decrease in the brain, they can cause mental illness. So we look at the biological. Let's look at the psychological causes now. Psychological causes include the type of personality traits that the person might have, such as there are some persons, they are just very pessimistic, always think negative. The glass is never half full, it's always half empty. Something happens and they go straight to the negative aspect of it, and they focus on the negative aspect, see nothing positive about it, and can't even come up with anything positive that would help them to feel better. Okay? Pessimistic persons. When we talk about psychological causes too, we talk about how people cope. Some persons, they just don't know how to cope with difficult situations. Some persons, they might turn to substances, and this is a negative way of coping. They turn to substances such as alcohol, or they turn to marijuana. And what this does, they give them a little good feeling for a time, but after the drug and the alcohol comes out of the system, the sadness and depression is still there waiting, saying, here am I. And the other persons who might be coping a little bit better, they know how to cope. These are persons who might rely on their faith. So they sing some godly songs, things that just uplift them, make them feel happy, make them feel better. Or there are some persons who rely on others for support, so they don't just stay at home and feel sad and down and lock themselves in the bedroom all day. These are persons who have one or two close friends who they know they can go to and talk to. Okay, so they seek out support. So when we talk about psychological causes, we talk about things like that. And then we have these social causes. And there's 101 different social causes. And right off of the top of my head is the situation that we're in right now with COVID-19. Anything that can cause us stress, we're talking about. When we say all these social causes, anything that can cause us stress. And we know for the past 6 months, we have been dealing with COVID-19. And for all of us who thought we were, well mentally fit or psychologically fit, it really gave us a little jolt that we had to settle ourselves, and stand firm, because it created situations of financial problem. It created situations where people were forced to be with each other, especially for the lockdown period, for long periods of time. Those families who are having difficulties interacting with each other, it forces them to stay in that situation. But that's just one thing. Even before COVID and now, we have so many other things that can cause us stress. The loss of a job. How many persons would have lost their job, not because of COVID, but for other situations? That can be a social cause. Abuse. All the different types of abuse can be as a cause. Whether it's physical abuse, psychological abuse, sexual abuse, all these can cause mental illness. So when we talk about the social causes, anything that can give us stress. It could be the children get a little more disgusting these times. We have to talk a lot more. The children are in the adolescent period. They're seeking their independence. And, pardon me?
Children home from school.
And the children home from school, the nurse is saying, and you are home with them. So that little 8-hour break also that you used to get from each other, you're just there. And you not only have to be the teacher at times, you have to be the teacher, you still have to be the mother, you still have to be cooking and cleaning, all these, and the friend also to these children. Thank you very much, nurse. So all these stressors are anything that can cause stress. All these things that can provoke stress, these can be the social causes. So as I said, the causes of mental illness, including depression, they are biological, they are psychological, and they are social. And I gave some idea of what each means, Now, let us look at depression itself now. Let us look at the symptoms of depression. Now, the symptoms of depression includes sadness, or the depressed mood itself. And the sadness has to be for at least majority of the week. So there's 7 days a week, so the person would feel sad for majority of the week, at least 4 days out of the 7 days. And the sadness for these days that you feel sad, it would be majority of the day. So it's not just feel sad for an hour and that's it. No, it would be majority of the day for at least 4 days. Majority of the week you're feeling sadness. Another symptom is the loss of interest or the loss of pleasure in doing things that you used to do every day. And you never used to have any problem with them. So you're accustomed to roll out of bed, make the breakfast for the children, straighten up the kitchen, cook, maybe clean up, etc., go to work and carry out your duties on the job. But all of a sudden, you can't even get out of the bed. You used to make the breakfast, you have to tell one of the children, make the breakfast, For days you cannot do it. Or you reach on the job, you are very present on the job, but you're absent. You you zone out. You look very sad and down, so persons, they don't even want to approach you. Some persons have a look that you realize, I don't even want to go to her because of how she's looking this morning or how he's looking this morning. That is it, okay? So you zone out. No interest or in doing the things that we used to do before. And then we could have changes in the weight. And why are we going to have changes in the weight? Because of appetite issues. Sometimes when some people sad, they could eat. So they eat down the whole place. And that is what they used to call. They eat. So they might gain some weight. Or the other persons, the appetite just gone. They ain't eating at all. So then those persons, you realize they lose some weight. Another symptom is the sleep disturbance. Sometimes when people depressed, they sleep all day, just in the bed lying down sleeping all day and all night without any problem. They're just sleeping. Other persons, they can't sleep at all. All night they're up, all day they're up. They have difficulty sleeping. Or if they do fall asleep, maybe they get out 2 hours, then they back up again. Okay? This is another symptom of the depression, the sleep problems. Also, another symptom is the concentration problem or problems with thinking. They're indecisive. They can't make a decision. That is another symptom. We also have the tiredness or the low energy, and you just feel drained and pulled down. That's another symptom. Okay? And there's also the worthless feeling and the hopeless feeling. That's another symptom. And when the depression...
What withdrawal?
Yes. Withdrawal can be another symptom, yes, because when they feel so sad and down, they don't want to interact with others. So you would find them pulling away and staying by themselves. Or if they're on the job, they just zone out. You realize, they might just be in a corner with their head down, or they, just focus on the computer, but they're just zoned out. And that is because they don't feel like interacting with people. And before the depression, they used to interact very well, okay? They never used to be home all the time and in the bed all the time, okay? So that can be a symptom too of depression, and more related to that depressed mood that you have, that making them just want to just stay by themselves, okay? And the depression, according to how severe the depression is, people will have recurrent thoughts of death, okay? And by that I mean, they would have thoughts thinking, okay, if I walk this street and a vehicle knock me down, I might die. Or if I'm going up the steps and, I reach the last floor, step at the step and I just fall back, I might die. Or you might see them have thoughts, suicidal thoughts and ideations without a plan. So they move from those kind of thoughts about death to suicidal thoughts, ideations without a plan now. So you hear these persons start to say, I just feel like to give up. I just want to die. I don't want to be on this earth anymore. I just want to die. But no plan is there whatsoever. And then you might have some who would actually make attempts, suicidal attempts, or what we call deliberate self-harm, in that they would do things and intentionally do things. I'm not talking about making a mistake, no, but intentionally do things to harm themselves. So these persons would do things like take an overdose of medication, or they might drink something that they know is hazardous to their health, and this is to actually harm themselves, okay? And then we have the others who would have suicidal thoughts or ideations, and they have a plan. And these are the persons who would say, okay, May 5th, 2020, that's the day I'm going to kill myself. And you would find they start to put their house in order leading up to May 5th. So whatever they need to get to harm themselves so they could die, they start collecting them piece by piece. So come May 5th, 2020, they would make that attempt on their life, okay? Now, I know I spoke about several symptoms of depression, but if you get one or two, if you notice, I gained some weight and I had a little difficulty sleeping, it doesn't mean that you have depression, okay? In order for you to be diagnosed with depression, You have to have the symptoms for at least 2 weeks, okay? And you have to have at least 5 out of all those symptoms that you hear me mention. And included in that 5, there must be the sadness or the loss of interest in doing things that you used to do before, or the loss of pleasure in doing things that you used to do before. Okay? Now, anybody can have depression. Because as I point out, the causes are biological, psychological, and social. And all of us here, we are biological, psychological, and social beings. So all of us anybody can get depression. When you think about children and you think about adults, how depression manifests itself could be different. Children would have more irritability. Everything bothers them, or you might see the behavior change and they start to act out. And sometimes we as parents, we say you're rude, or especially if they start to, in the adolescent age, or you're playing man and woman now, okay? And it could be the depression. For adults, we tend to have this low mood and the sadness and the depressed mood that we can pinpoint more easily than children. Now, depression, we could have mild, moderate, and severe symptoms, okay? So everybody don't have to be the severe case where they try to harm themselves, or they don't have to be the case where they just lie down in the bed not eating at all for days. No. You could have some moderate symptoms, and by that I mean you might still show up to work, you might still be able to do the breakfast and do some of the things, but there's a persistent sadness that is there. And there must be at least 5 of the symptoms present, okay? When you talk about depression, we have to be mindful that there are a lot of disorders out there that can have depression as a symptom. For example, we have what we call persistent depressive disorder. And what's the difference between that and the major depressive disorder? Well, for that disorder, the person must have these depressive symptoms for at least 2 years. Now, I realize, persons open their eyes, make a little gesture and say 2 years. When we say 2 years, we don't mean every day for 2 years. No. When they have persistent depressive disorder, they might be good for 2 days. So 2 days, daily functioning, excellent. Mood is good. And then after 2 days, the next 2 days, they have some of the symptoms that you hear me mention for major depressive disorder, okay? They're not eating, they're not sleeping, they're just feeling sad and down, crying all the time. And they can have severe symptoms or mild symptoms, okay? And then the next 2 days, you see them good again. So it's almost like a little YOLO. Today you're good, and tomorrow you're not so good, and the next day you're good, and that would happen for at least 2 years. We also have depression that happens in the postpartum period. When there's a woman who gives birth, right after birth, sometime after birth, they could develop what we call postpartum depression, that is depression in the postpartum period. And this is totally different to the baby blues that we would say the new mom would have. Because with the baby blues, you would find that the symptoms would decrease day after day. But with the major depressive disorder in the postpartum period, day after day, the symptoms increasing. So more and more, you have more symptoms and more severe. And daily functioning is affected also. Okay? So that's depression in the postpartum period or postpartum depression. And we also have depression, with psychosis too. In that, yes, the person have that mood element with all the symptoms of depression. However, in addition, they have those psychotic symptoms in that they might have the hallucinations, what we call hallucination, and that's when you hear them. The hallucinations are associated with the 5 senses, Okay, hearing, so they might be hearing things that only them alone could hear, seeing things that only they alone could see, smelling and tasting and feeling things that they alone could see and feel, and everybody else there, and we cannot see it on them, we cannot smell what they are smelling, but they are picking it up. Because the brain is malfunctioning and is picking up things that does not really exist. Okay, so you would see them have those different types of hallucinations, and most likely they tend to have these auditory, those hearing ones, the auditory or the visual ones, where they're seeing things that only they alone could hear or see, and it tends to be in line with the depressed mode. Okay, so it's not just out there. So they would, if they hear a voice, the voice is going to tell them, "You ain't see nobody like you," and that gonna make you feel even worse. Or the voice would tell them, "You can't do nothing right at all." These are the kind of things that they would hear.
And sometimes when they see two persons talking, they feel they're talking about them.
A little paranoid. They get a little paranoid. Okay? So those are the symptoms, the psychotic features that we tend to see associated with depression. And there's another type too that we would hear about, where we have seasonal depression, but it's not really here in St. Kitts, and this is more prominent in the US, where they have weather changes. And that when during the winter, people tend to suffer with depression, and that is because the sunlight is not there. So we are so blessed here in St. Kitts that we have the sunlight all year round. So we could always just go out and take a walk in the sunlight, and that is going to lift our spirits. And then we have the depression that is associated with what we call bipolar disorder. And bi means two, so it means it's two disorder: the manic part and the depressive part. Okay? And we will have to be able to differentiate, is this bipolar disorder or is this the major depressive disorder? And how we do that is that for bipolar disorder, we cannot diagnose bipolar disorder unless there's a manic episode. So whenever the person have a depressive episode, we would assume that this is major depressive disorder unless or until the person develop a manic episode. Okay? Any questions at this time? Pardon me? Okay. Any questions at this time? Okay. Now, depression, as I said, a lot of times people might tend to confuse sadness with depression. Okay? What do you all think the difference is? Okay? Sadness and depression. What do you all think the difference is? The duration. Okay. Tell me more about the duration. What do you think about the duration?
Sadness could just be for a moment because something spontaneously happened and make you sad.
Mm-hmm.
But the depression is something that is ongoing, that will last hours or a day or two.
Mm-hmm. And I see the nursing really coming out there. Yes, the sadness, okay, is usually triggered by something specific. Okay, so you had an argument with your child, or you had an argument with your significant other, or something specific happened on the job, and that made you feel sad, as you say so rightly, nurse. And the sadness is going to last for a day. You might feel sad, or even throughout the day, one of your friends come and say, "Okay, girl, let's go for a drive," and just get rid of that sadness, make you feel better, and you feel so much better, and the sadness gone. Okay? The sadness is a normal emotion. Just like love, anger, happiness is a normal emotion. But when we talk about depression, we talk about disorder. And associated with that sadness or that depressed mood, remember we say we need at least 5 symptoms. So there's going to be either the appetite problems, or the sleep problems, or the concentration problems, or the recurrent thoughts about death, or the fatigue and tiredness, loss of interest in doing things that you used to do before. So the depression has more symptoms, additional symptoms attached to it that would make it called the depression. But the sadness is just the sadness. Okay? It is just the sadness. All right? So that's very good. That's a clear distinction. Also, the duration, as you said. Depression has to be at least 2 weeks. Okay? 2 weeks, and as I said before, 5 days at least. At least 5 symptoms, and the depression symptom has to last, or the sadness has to last at least 4 days, and for majority of the day during those 4 days. Now, let us look at treatment. Okay. How do we treat this depression? Well, we said the causes are biological, psychological, and social. Well, the treatment is the same as the causes: biological, psychological, and social. So in terms of biological treatment, we talk about medication, talk about antidepressants. Okay? That's the biological treatment. Now, the treatment depends on the severity of the depression. So if it's a mild depression, we're not going to do biological treatment. Okay? We might just do psychological treatment. And what is the psychological treatment? Therapy, counseling. Okay? Cognitive behavioral therapy or talk therapy, in that you just come and just talk with the person using different psychological orientations, and you talk to them about coping, give them ways to cope, etc. Okay? That's psychological. And in the social, very important. Okay? That is all the social activities that you can be a part of that will help to lift your spirit. So while as when the person is depressed, they want to stay in the house by themselves and don't interact, we want to get them out. And we know that, when you're depressed, the interest is not there in actually coming out and doing things. So, it's a push. You have to push yourself to come out, interact with others, going to church, taking walks, visiting your relatives or your friends, going to the movies, going to the beach, just getting out of your house and participating in all sorts of different social activities. Depression, we can go on and on and on about depression. But I don't really want to bore you too much with too much things at this moment. So, I think we can end it there for today, but any questions, anything anybody wants to know, anything that anybody want to pinpoint on? Okay.
About the way in which somebody carry themselves, like you realize
The
way in which you realize their appearance change, the way in which they carry themselves, they have to carry themselves nice and modest, and all of a sudden the real would look like here. That's the sign too?
Very good, very good. Okay, and that sign comes in the loss of interest in doing the things that they used to do. So before they make up the face, the matching outfit, and you look at them, you say you took some time to put yourself together. You bathe and you perfume and you fix up yourself nice, and then all of a sudden you stop. Okay, so that is a symptom when you notice the change in the way they carry themselves. Yeah. So you could actually look at some persons, and in the community we look at persons and we can say something going on with the person. Okay. Also the way they walk in, when we have what we call another symptom when you just feel slowed down, no energy at all. So the person accustomed to brisk, and you go in, and then all of a sudden you see them just barely going. Okay. That something is going on with them, and it can be depression.
I have a question. What about if you are actively doing the things that you normally do, but the feeling, this nagging feeling is there every day at some point in the day? Would you consider that person to be depressed even though they're still going about your normal activities?
Depression can be mild, it can be moderate, and it can be severe. And when it is mild, some persons are able to carry on the activities that they used to carry before. However, within themselves, they feel down, they feel sad, they feel empty, they feel drained, but they're still able to go, not as how they're accustomed to, okay? Because there's going to be a change in the functioning. Okay, so if they were excellent before, they might be good. And good is still all right, okay? It's still all right, but you know, it's a drop from excellent. Okay, so these persons can have depression too. And another thing with depression, sometimes we tend to focus a lot on these symptoms that I mentioned, but sometimes the symptoms are somatic, eh? And by that I mean the patient have all sorts of pains. Unrelated pain in the head, pain in the chest, pain in the foot, pain in the hand, all sorts of pains. And it could be depression, or all sorts of digestive problems, the stomach feel, upset, and it is depression. So that's why it's very important that we take a vital history from the person, because when we take that history, we would realize that underneath all these pains and discomfort in the stomach, there is depression. Okay? There is depression. Sometimes the person might get a news from the doctor that's not so good. They have an illness, or they're diagnosed with diabetes or hypertension, which requires that they have to make lifestyle changes. Okay? And the lifestyle changes is not just until the sugar stabilizes. No. After the sugar stabilizes or the diabetes is under control, you still have to continue them for the rest of your life. And this can cause people to feel depressed because there are certain things that they have to give up. Okay, in terms of the meals that they used to eat, etc. They have to make some changes there. Okay, and we know the healthy stuff we usually take a little bit more challenging for some of us to eat, the healthy stuff. But those things that are not so healthy, we need no encouragement. We need no encouragement. So it's a total lifestyle change, and it could be difficult for them. It could be difficult for them. Okay?
Because you mentioned one of the causes could be sexual abuse. Mm-hmm. How does the individual get over sexual abuse?
No, that is so true. One of the causes can be sexual abuse, and it doesn't even matter when the abuse happened, whether it happened in childhood or in adults. It's very traumatic. And for that, you're going to need trauma therapy. You're going to need therapy, psychotherapy, because you have to learn to reach a point where you can cope with what happened. Because at the end of the day, the abuse happened. And we can't undo it. What we have the power to do is to reach a point where we can think about it in a way that we have peace of mind. Okay? So it's not every time we think about it, we fall apart or we zone out, we go into a depressive state. We need therapy so we could reach the point that even when it comes in our head, something trigger it and it comes back to our memory, we're able to still be at peace with it. So it really needs therapy, okay? And therapy that addresses that trauma, because it is traumatic. And especially if this abuse was continuous, very traumatic. Equally traumatic is where it's a one-time thing, but even when it's continuous, it's quite traumatic. Okay? Any question?
I like the psychology field, right?
Mm-hmm.
But more for like, not to exclude anybody, but more females and like teenagers and stuff like that. But how does the psychologist, herself or himself, deal with everybody's problems in their own mind at the end of the day?
That is a good question. because what we have is that every day and every session somebody come and they get to dump it here, and then they could leave it here and go. Okay? But we are trained that when we sit in the psychologist chair, yeah, we are the psychologist. I'm Dr. Crawford, clinical psychologist. But when I get up out of the chair, I am Cherrilyn. Okay? So whatever is dumped there stays there.
95% of the times.
90.
At some point, there would be something that is dumped that leaves the chair with the psychologist.
No, but we are not supposed to take it with us. Okay, so we are trained to know that these things that we are dealing with is not ours. Okay? They are not ours. They belong to the persons, and we are helping them to cope. Okay? I'm not saying that, something traumatic might not happen down the road and you feel, okay, that was something traumatic. But to take it as, okay, this is my situation. So it could have an impact and cause you psychological distress.
Psychologists themselves have to have coping skills as well.
Very important coping skills. And we also have conversations with other psychologists, not to carry person's business. So it's not that I take in your business down by this other department, psychology department, business, but sometimes we have, therapists for psychologists too. So if for some reason something really leave, an imprint on us, okay, we get some help. We get some help with it, okay? But as I said, it's not to carry the business, the person business.
But sometimes the business needs to be carried.
Clarify for everybody, yes, and yes.
Like if a client comes to you and they're severely depressed and they say they want to kill themselves and they bring the plan to you, well, the business has to be carried because they can't just leave it there.
Very good. Very good, okay? We have a duty to do no harm, and we have a duty to warn as psychologists. So whenever anybody come to us, okay, before we start anything, we have to let them know. We have a duty to warn. And that means if you tell me and we explain to them, okay, whatever you tell me is confidential. However, we have a duty to warn. So if you tell me something that I need to warn somebody about, I would have to break confidentiality. And the only 2 reasons that we have as psychologists to break confidentiality is if the person said, as you rightly say, nurse, they are going to harm themselves and they have a plan. Okay? We have to protect the person from harming themselves. And the second thing is if the person said, I'm going down the road to harm John Doe or Jane Doe. We have a duty to protect persons. So those are the only 2 situations, okay, in which we breach confidentiality. In children, that's a different thing. Once there's abuse, sexual abuse, physical abuse, the child under 18, we have a duty. We have a duty to warn because we have to protect the child.
So will a child under 18 come to your office without a parent?
We do see children without their parents. Sometimes the parents is outside. Okay? The parents is outside because therapy is individual. And
I think she means like, say my daughter has a problem
Mhm.
and she just passes and see the office sign and she walks in and says she wants to talk to the psychologist.
our doors are open.
So you could safely talk to
Mhm.
a child without.
Yes, our doors are, no. We don't turn back anybody at all, okay? So if the child show up to our doors, we're going to listen to the child because sometimes it's a cry for help. Because then when we say, oh no, we can't see you, go and look for the parents, and the child and the parent is not getting on, maybe it's the parent is the problem, okay? And then, they turn to us as, okay, this is the last hope here. And then we say, go bring the problem to us. Okay? So we, the child show up, we see the child. And as I said, even when parents recognize that, okay, something is wrong with my child, they're not behaving as they're accustomed to, something is off here. Yeah. You bring the child first session, yeah, we hear what you have to say, and then we talk to the child. After that, we see the child individually, and we only include the parent when we think that it is necessary. And whatever the child tells us, it's confidential. Okay? Now, if something is going on in the home, that I said, if there's abuse, whatever type it is, and we have to intervene, we always try to get the child consent first, okay? Because we don't want to feel like we just run behind the back, go on, no. And then they shut down. So there's that little thin line there because we still want them to trust us. So we work with the child, and we convince them, and we talk with them, you know. Need to bring in your mom and dad, or we need to bring in your dad, you know. Give me permission. This is what I would say. Let us agree on what I can say at this time, because sometimes it's peace, you have to give the parents things, eh? Because I've had children who say, listen, my mother can't deal with this, you know. My mother would fall apart if you tell her this, okay? Children who know their moms. So then we say, okay, let us work on just giving her this part first. And I like to bring them in when I talk to the parents. I like to bring them in with the child inside there. Because that way the child hear everything that I say to the parents. So they're not wondering, I wonder if Dr. Crawford tell her this part. Or I wonder if Dr. Crawford said, I tell her not to tell her this part, you know, and things like that. No, I like to bring them in with the parents so they hear exactly what is said, and they gain trust, they open up more, and that is what we want. We want persons to be able to open up and be honest, because unless they are honest, we won't be able to help them properly. Okay, so we really want people to be honest. And as I said, we are confidential, okay, and only under those circumstances, as I mentioned before, we can breach the confidentiality. Okay, all other reasons, no. Another question? Okay. If we have no further questions, come, don't leave here with the doubts. Don't leave here with the doubts. You hear me? Come, don't leave here with the doubts. And I know the feel that you are in your interaction with all sorts of different persons. Okay? So I know there are things that would pop up in your mind. Okay? This is the place to clarify them.
How would the psychologist deal with a situation where I come to you, but it's not about me? Like, you notice you have a friend who get in a bus late, a grade, and she don't want to go out with you no more. She might have she boyfriend or she husband, or whether it's a parent or somebody, and you know, I come to you about the situation, but how would you get to that person to get them to speak up, because I can't get them to come?
That's a ticklish one. That's really a ticklish one, because you say if you are trying to get them to come and they don't want to come, it's difficult because we can't help them if they're not there. What sometimes I suggest, okay, you give them my number. Let them call me personally. Or you ask them if you can give them, you know, my number. Or give me their number, sorry. So I would just talk with them and see, you know, if I could persuade them to come in. Okay? But those is difficult, especially when we're dealing with domestic violence and things like that, you know. Sometimes, you know, people, it's very difficult for them to leave such a situation because it's like it's a cycle. Because the person who is abusive, they're not abusive 24/7, you know. There are sometimes when they're good, just like all of us. We have our good and we have our bad. Okay? And when we're good, sometimes we're really good. And when we're bad, as you said, no, we're really bad. And sometimes person are thinking, but you know, this person is nice, he did this, and the person did this and that, and they could be between me. And he only when he hit me, you know, but everything else good. Everything else good. Okay? But these are situations that we know could become very problematic in the future, because sometimes the hitting goes more and more and more abusive till life-threatening. And then the nurse here said, death do us part. Until death do us part. So these really need intervention at times. And as you said, if you have lips, you know, being swollen or bruised, or as you say, bursts, etc., you know, we're talking about serious abuse here. Serious abuse here. So the person might just need somebody to talk to. Okay? And we're not the police. So you could remind them, you know, we're not the police. We're just there to support. Okay?
One question. We have, you know, in society right now, we have a troubled society. And some persons at this time, they want to speak to somebody. And even though they are appointed psychologists, persons still afraid because they have mistrust, right? And sometimes you tell somebody something in confidence and just to turn your back and it face to you. And so people have mistrust. They don't know who to talk to. I mean, not even their parents, not even their close friend. They would find sometimes, you know, out of the ordinary, you would find somebody come and say, can I speak to you? I mean, and you know, you can't breach confidentiality. Even little children. How many years will come and say, you know, she will talk something to you. Keep the secret. When you tell them a secret, they're going to talk to you. So, you know, we have a lot of mistrust. I don't know how we can get, you know, the community come back, you know, where we can trust somebody and feel this, you know, this sense of belonging.
I hear you, nurse, because in order for therapy to be effective, the person, the client has to trust that the therapist is going to hold whatever they say in confidence and trust that the therapist is prepared, you know, academically and from experience to really help them. And as you say, we come from a society where parents used to say, whatever happens here stays here. You know, you're not supposed to carry out anything no matter how bad it is. You know, whatever happened here stays here. You're not supposed to carry out anything outside to tell anybody to look for any help. No, you're supposed to stay there and suffer there. And that's the society that we came from. However, with, you know, guidance counselors in the school, with mental health being at the hospital now, in terms of a psychologist from 15 years, with the counseling center being in place for more than 15 years, I think that we are making strides in terms of trying to break all that cycle, as the person in front here is saying, and to let people know that we are a set of professionals that you can trust. We are not the neighbor where you go and you tell something, as the nurse in front of you say, and then you hear it. Before you reach down to the bottom of the road, somebody down there watching you funny and could tell you everything that you say, okay? We are bounded by confidentiality. So we are not just the neighbor, we are not just the, you know, the teacher, we are not just the shopkeeper or the storekeeper. No, it's a profession. And we are bounded by we are bounded by confidentiality, so we cannot breach it, and only under these circumstances that I mentioned. So I would like people to know that you can come and talk to us. You can come and talk to us. Sometimes we have persons who, you know, they come and they say, okay, I don't want my mother to know, adults, and they say, no, even when she comes, we not to discuss this and we not to discuss that, okay? And we make sure that whatever they tell us, if they say don't touch this topic, we don't touch it. And even if the parent bring up the topic, we don't touch it. Because sometimes people think, oh, if I go to the doctor and and she bring the mother along, and we're talking about adults, I'm not talking about children, or they bring the best friend along, that means, okay, we could talk all the person's business, because why would she bring the best friend? No, we have to hold things in confidence. Okay, and as I said, we are professionals. We are professionals. And another thing that we have to touch on too is the stigma that we have associated with mental illness, because some people feel like, okay, if you have mental illness, it's the end of the world. And sometimes when people have mental illness, some people tend to look down on them and want to treat them a kind of way. And when they talk with you, you're wondering, they're stable today or not? No. Anybody, as I outlined to you, anybody can develop mental illness because it's a biological, psychological, social, and as I said before, we are biological, psychological, and social beings. Okay? And we want people to empathize with persons who have mental illness and try and offer support to these persons. And support, we're not just talking about financial support. We're not saying that. But a little encouragement. Okay? A little encouragement goes a long way, a positive word. Just lift person. Even when you think about our own selves, sometimes we feel down and we just pull out a positive word, whether it's out of the Bible or it's out of a song or a phrase, and it just lifts up our spirit, Sometimes that's just what the person needs. Sometimes it might be a little touch on the shoulder. It's going to be all right. And just like that, the person's mood shifts and they feel better. So I'm hoping, after today, you all would view depression differently. You all will be able to pick up the symptoms of depression, and you all would be able to encourage persons to seek help. You could tell them, just give it a try. I had one person who came to my office, for a session. The doctor had sent him, and a young man too, okay? And the doctor sent him for some therapy. And then after the first session, he said, but this ain't so bad. I thought it would have been worse. I thought it would have been every minute feeling or something, but this was actually good. I'm coming back. So sometimes you just need them to get their foot in. So you could say, just give it a try. Yeah. Okay. Yes. And you know the session lasts 45 minutes or so after the first 10-15 minutes you go and you and the person, as I said, sometimes we just need them to get their foot in. And when they experience it, they get to like it and they become comfortable. Yeah. That is so true. Because sometimes, persons are hesitant, and that is a good point, nurse. Because you come, nothing wrong with me, nothing, everything. And then you're there and you talk with them, and as you said, nurse, so many things come out. And sometimes just venting, and by venting I mean you're just talking about it, they feel better and they say, okay, I'm going to come back again for another session. Okay? So as I say, I'm hoping that, out of this session today, we would have persons who would not just know about depression and have some idea of mental illness, but persons who could be converted into supporters of persons who have mental illness. So I want to thank Nurse Rollins for inviting me today to participate in this discussion about depression, and I'm hoping that I get another opportunity to come back again and talk about something else, because as I said, mental health is my passion, and my wish is that all of us would be well-balanced persons, okay? Well fit mentally and psychologically. I know a lot of times people talk about being physically fit, but I would like persons to be fit mentally and physically, in that they do things to help boost up their mental well-being. Okay? So, once again, thank you, and thank you.
Dr. Crawford, good afternoon. On behalf of Kare Nursing Agency, we would like to thank you for taking time out of your busy schedule and coming here today and enlightening us on depression. I can assure you that what you have taught us today, we will share it not only to our loved ones and our relatives, but to our patients, in which we will impart what you have taught us, and also with ourselves. Thank you once again, and we hope to see you in the not too near distant future.
Thank you, dear.